Good morning, and thank you for joining us today for our webinar, The Mental Health Parity and Addiction Equity Act, What You Need to Know. In this session, we'll talk about the Mental Health Parity and Addiction Equity Act, what it is, the challenges employers face in achieving true parity, and we'll touch on the proposed regulations for 2024. Since we've gotten questions, the Alliance Network is compliant with this act. We'll continue to monitor what happens in 2024, but there's so much more to it than just a network, which is why we're here today. This is part one in a two-part series. The second part will be on January 18th, and we'll dive deeper into the regulations. We appreciate all the great questions we got before today's webinar, and that's actually why we ended up having a two-part series. The goal for today is helping you understand the Act and ensure you're ready to meet its requirements. I'm Jennifer Austin. I'm the Senior Director of Strategic Marketing and Employer Engagement here at the Alliance. And I just want to start out with a few housekeeping items. First, you are all in mute mode, but please know we still want to hear from you. You'll find the chat feature in GoToWebinar to the right-hand side. So if you can use that to ask any questions or talk about any technical challenges, our team will get back to you. In addition, you'll see that there's a handout section. In that section, we provided two handouts for today. The first is John's slides to go through because we know this is a meaty topic and you might want to take notes along the way. The second is an employee handout. This is really meant to help foster an environment of employee well-being and inclusivity when it comes to mental health. You can download both of those directly from the GoToWebinar platform. And often we're asked, is this going to be made available afterwards? Yes, the recording will be made available on the events page, and we'll also email it to attendees afterwards. I also want to just take a second to thank our year-long sponsors, National Cooperative RX and Delta Dental. Without your support, we wouldn't be able to bring this great programming to our employers and their partners. So before I introduce John, I just wanted to take a second to talk about why we're talking about this. As an employer, you play a pivotal role in the health and well-being of your workforce. The Mental Health Parity and Addiction Equity Act is a federal law that requires that health insurance plans provide equal coverage for both mental health and medical services. We just want to make sure, this act just wants to make sure that you're giving equal access to those mental health and substance abuse treatments as you are for regular medical services. But ensuring that you're compliant with this act isn't enough. It's not just about meeting the legal requirements. It's also about fostering that culture of health and productivity for employees and their families. Studies show that when we prioritize our employees' health and well-being, it leads to higher employee satisfaction, lower turnover rates, and increased productivity. So that means you invest in your people and they invest back in you, and that's just truly a win-win situation. So now I'm going to ask John to come on. He is going to be talking through this. Mr. John Barlament is a friend of the Alliance and one of our favorite speakers. He is an employee benefits attorney who works with employers and health plans on various legal issues with a focus on health and welfare plans. He's recognized as a national leader and has been interviewed by leading publications, including the Wall Street Journal. Thanks so much for joining us today, John.
All right, thanks, Jennifer, and thanks everyone for being here today. I hope everyone can see my screen. Jennifer, do you see the screen, I'm guessing?
It looks great.
Hey, fantastic. Half the battle right there. So thanks again, everyone, for being here. And yeah, excited to talk about this kind of a hot topic in terms of the compliance world. I mean, I don't have a bullet point on this specifically, but just so you know, the Department of Labor and the IRS and CMS, Centers for Medicare and Medicaid Services, enforce this rule. And in the most recent data that I saw, about half of all Department of Labor investigations involve mental health parity. So you think about all the different benefit laws that they have to enforce, ERISA, COBRA, other ones, mental health parity kind of takes up about half their plate. So it's a very hot topic. And so we're going to kind of walk you through it here today. We do have an acronym slide. Everybody, I'm sure, loves acronyms. Benefit lawyers love acronyms. And so these are some of the ones that we'll cover here today. MHPAEA, of course, is the main one here. We'll also talk about some other changes under like the Consolidated Appropriations Act, the CAA. We'll talk about some quantitative treatment limitation rules that you should be compliant with, QTL rules, kind of ignored, I would say, by employers in general, but probably shouldn't be ignored. If you've never looked at those, you probably should. We'll talk about those. We'll talk a lot about non-quantitative treatment limitations and QTLs and how these rules apply to both mental health and substance use disorders, which are kind of in one bucket, in one category. And then those always get compared to how those NQTLs apply to medical surgical MS benefits. So again, we'll walk through this and would be delighted in terms of questions. You know, if you do have questions, feel free to put them into the chat. There's really no dumb question here because this is a very complicated sort of area. So anyways, in terms of how we got here originally, well, there was sort of a belief in Congress that health plans, both fully insured and self-funded, were not treating mental health benefits and later substance use disorder benefits fairly. That sometimes what we would have seen would be there'd be different deductibles, different limits, different copay, different co-insurance, which applied to mental health benefits, or even sometimes like a $10,000 mental health lifetime limit, but no limit on medical surgical benefits. And so Congress basically became annoyed and said, you know what, we're going to impose some parity rules here, the Mental Health Parity Act of 1996, so it goes back a long ways. It was expanded over the years here into MHPAEA, and the most recent expansion is through that CAA, Consolidated Appropriations Act of 2021, which was signed into law in December of 2020. So again, it's really focused on parity between medical surgical benefits and mental health substance use disorder benefits. In terms of the plans which are subject to the laws, unfortunately, many plans are subject to these rules. So it generally does apply to group health plans, typically major medical plans, accepted benefits like most health FSAs, dental, vision, etc., generally excluded, so you usually don't have to worry too much about mental health parity with respect to those kinds of benefits. Church plans are not exempt. Sometimes church plans avoid some of these rules. They don't avoid these rules here. Small plans or retiree-only plans generally excluded. Those are generally considered accepted benefits. That's helpful. We do have a number of clients who have retiree-only plans, and they don't have to do this MHPAEA analysis that we're going to be talking about here that you're going to have to do or you should be doing for your active employee plans. In terms of what a small plan is, again, you could have retiree only, which has 0 active employees. That's a pretty clear exception. Also, some employers may have a small plan by themselves and may be self-funded. So you could have maybe 45 employees and be self-funded. Normally, you have to have a little bit more before you go the self-funded route, but it's possible. We have some clients who, have, employees measured in the dozens and are self-funded. And so if you're in that category, and if you had at least 2, but not more than 50 employees on business days during the preceding year, then you would generally be exempt from this rule, which is great. Again, I don't think that'll apply to too many of you out there, but there is that possible exception. There can also be a different rule for governmental plans, like plans of a public school, city, or county. In some situations, the upper boundary for them can be 100 employees, not 50. There also used to be an opt-out provision which applied to governmental plans where they could voluntarily opt out. That provision has recently gone away, so that doesn't apply any longer. Finally, there's kind of a quirky increased cost exception, which I have had very few clients ever really try to comply with, but basically if there was an increased cost of 2% in 2010, or at least 1% in any subsequent year to comply with mental health parity, then you can opt out, you can basically be exempt, but the exemption only lasts 1 year. So you would have to kind of continuously look at all these provisions and sort of deal with it on a year-by-year basis. You need an actuary to provide backup and documentation for it. So it's not the most practical exception which is out there. And again, it's rarely ever looked at from an employer perspective. In terms of MHPAEA's three main requirements, let's talk about them. And in terms of importance, the first one is probably the least important that's out there. You're probably already compliant with it. You should be compliant with it. Basically, what it says is that if a plan has an annual or lifetime dollar limit for medical surgical benefits, that you have to apply those same dollar limits basically for mental health or substance use disorder benefits. For example, it would have been problematic to include a $1 million lifetime limit on medical surgical benefits, but a $500,000 lifetime limit on mental health and substance use disorder benefits. Why don't we see those kind of plan designs anymore? Well, basically, the Affordable Care Act eliminated dollar-based annual and lifetime limits for essential health benefits, EHBs. So basically, the ACA kind of solved the problem. It resolved the issue by saying that, hey, you know what, we just aren't going to have dollar-based lifetime or annual limits for most benefits, these essential health benefits. So this is technically a MHPAEA requirement, which is still on the books, but again, not much of a practical impact any longer. The second requirement is that financial requirements such as coinsurance, copayments, and deductibles, and quantitative treatment limitations, those QTLs like visit limits, cannot be more restrictive against mental health, substance use disorder benefits compared to medical surgical benefits. And we'll give you an example of what this means, because when I read these words, I appreciate that it sounds like legalese, and it is legalese, but we'll give you an example of what that means in a slide here or so. Also, there can't be separate cost-sharing requirements only for mental health and substance use disorder benefits. So, for example, you cannot draft your plan to say that there's a $1,000 deductible for medical surgical benefits and a $500 deductible for mental health substance use disorder benefits. And let's pause for a second there, because you might say, well, wait a minute, that sounds good. We're treating medical surgical worse by having a $1,000 deductible versus mental health, which gets a better $500 deductible. So you can see how that actually might be okay. But the rules just say, no, we don't want to mess around with that. We don't want separate deductibles here for mental health benefits. So even though the deductible is better, it would violate MHPAEA because it is separate. So again, that's sort of how that particular rule works there. And again, that's a very unusual plan design. We don't typically kind of see that any longer here. All right, other QTLs rules, and this one's a little bit more complicated, and that's why we're going to kind of go through it in a little bit more detail here. Also want to emphasize that if you have never done this sort of QTL analysis before, it is a good idea to do it. As you'll see from this example, it is one of those rules where you cannot tell if you're compliant, generally speaking, unless you actually do the test. It is possible that you would have a very simple kind of plan design without a lot of categories and different levels of varying copayments, coinsurance, in which case you're probably fine. But if you have anything which gets into like additional levels of copayments, coinsurance, where it kind of varies, then you have to definitely run the test to figure out if you're compliant or not. And so what does this test do, the QTL test? Basically, you start off by identifying the different classifications in your plan, like inpatient, in-network, and emergency care. So 6 primary different classifications. And then you verify whether the financial requirements, like copayments and coinsurance, apply to at least 2/3 of the medical surgical benefits in the classification. And if no, then you can't apply any of those to mental health or substance use disorder benefits. So again, you kind of got to impose enough of a bite against medical surgical benefits in order to be allowed to impose any kind of bite, copayments, coinsurance, against mental health benefits. So you got to pass that 2/3 threshold as an initial matter. And then if you do pass that 2/3 threshold as an initial matter, then you have to do another set of mathematical tests here. You need to make sure and verify what single level applies to more than 1/2 of the medical surgical benefits. So again, you kind of figure out, okay, what's the most common, say, copayment amount that we apply under our plan in this particular classification of, inpatient in network, for example, or outpatient in network. And let's walk you through an example of that, because if you are not at 50.1% or higher, then you have to do kind of a mathematical aggregation, which is a little bit odd and requires some kind of number crunching. In this example, let's suppose that a particular self-funded plan for its outpatient in-network medical surgical benefits, that it projects benefits for the next plan year as follows. Let me just pause for a second there. So again, it's kind of projected benefits for the next plan year is the test. And again, that's a little bit weird, right? That means you have to have the data for the previous plan year or for a recent plan year, so you can kind of project it forward. And so again, that's not something that employers necessarily think through or think about. And in this particular plan, there's 5 different levels of co-payments for this particular classification. So in some situations, the plan imposes a $0 copayment. Others it's 10, others it's 15, others it's 20, others it's 50, kind of depending upon the nature of the medical care at issue. So $0 copayments might be, preventative care benefits or something like that. And then we have other varying classification of benefits here. So the plan projects, let's suppose that the plan projects that it's going to pay out $1 million in benefits. Low, unrealistically low, I appreciate that, but I'm just trying to keep the numbers simple. And so at the $0 copayment level, it projects $200,000 worth of benefits. At the $10 level, another $200,000, $15 level, another $200,000. At the $20 level, it projects $300,000 worth of benefits associated with that particular copayment level. And then at the $50 one, it's $100,000. So if you add those up, it equals $1 million. And then what you do is you first of all look at the percentage of total plan costs, which is basically those numbers. For example, $300,000 at the $20 level, $300,000 divided by $1 million is 30%. Of the ones that are subject to a copayment, what does that mean? That basically means that you drop out that $200,000 at the $0 level because that doesn't really have a copayment, and you kind of rerun the numbers. So it works out that that the $50 amount is equal to 12.5% of the benefits. The $20 amount is 37.5% of the benefits. The $15 copayment is 25% of the benefits. $10 copayment is 25% of the benefits. And I think there might be a slight error here. It really should be like 200,000 divided by 800,000, not 200,000 divided by $1 million. So my apologies. We should have dropped it through to 800,000 instead of $1 million when we were running those numbers there. All right. So the first test is are 2/3 of the benefits subject to this particular copayment? And the answer is yes, because again, if you flip back here, 20% are at the $0 level, so there is no copayment. But the other 80%, if you add them up, 20% plus 20% plus 30% plus 10%, 80% of benefits do have some kind of copayment subject to them. So 80% is higher than 2/3, so that's good. That means that we've passed the first hurdle. That means that we can impose a copayment in this classification for mental health and substance use disorder benefits. Then, as you recall from the previous slide, now we have to figure out, okay, which of these meets at least 50.1%, more than 50% of the benefits. And if you look back at this chart, none of them get to that 50.1% level. The highest one that we have is in the $20 copayment level. That's at 37.5%. So 37.5%, not 50.1%. So what do? We take the highest one, the 37.5%, and we combine it with the next one that's higher than it, which is 12.5%. That's the $50 copayment. We add those two together, and that gives us 50.00%. But again, we needed to be greater than 50%. So then we drop down to the next copayment level, which is $15. And when we add in the $15 copayment level, it works. We end up with 37.5% plus the 12.5% plus the extra percent from the $15 copayment level. So now finally we have a number which is more than 50%. And then what does that mean at that point? That means that our mental health and substance use disorder copayments are capped at $50. Again, because if you go back to the slide, you took the 37.5% for the $20, you added in the 12.5%, that got you to 50.0%, close, but no cigar. So then you have to add in the $15, which is at 25%. So finally, you're at 75%. You're at a level which is sufficient. But that $15 cap means that the mental health and substance use disorder co-payments should be capped at $15. That's kind of weird because the medical surgical benefits can still be subject to the higher copayment level. So they can be subject to the $50 copayment level or a $20 copayment level. Again, you can have higher ones there. And that is an odd plan design. I sometimes talk to clients about how this isn't really parity, it's more what I call super parity, where basically mental health and substance use disorder benefits get, in some situations at least, get treated better than medical surgical benefits. So if your plan had these numbers, you would have to build into the SPD, for 2024, let's say, that your mental health substance use disorder copayments are capped at $15, but medical surgical can be $20, it can be $50, etc. So again, it's a strange result. And if you haven't ever done this QTL test, it is a very good idea to do that kind of QTL test to get up to speed and make sure that you're passing. One quick final point on this before I go forward. Note that what kind of causes the problem here is that we have 5 different levels of copayment amounts. If you only have like 1 or 2 levels of copayments, you're much less likely to run into this problem. The difficulty really comes in when you have all these different kind of varying levels, because then suddenly the numbers get hard to get to that 50.1% level. In contrast, if you have 1 or 2 levels of copayments, it becomes a lot easier to get to that 50.1% level. So again, I realize that that's a lot, but that is something that you should definitely consider doing, especially if you haven't run that kind of test in the past. All right, let's change gears. Let's go to the next test here under MHPAEA, which is NQTLs, non-quantitative treatment limitations. What are these? These are non-numeric limitations, generally speaking, on the scope or duration of benefits for treatment. So I describe these as kind of softer limitations under a plan. A hard limitation would be you have a $2,000 deductible, or you have this level of out-of-pocket, or a $20 copayment, or 10% coinsurance. Those are kind of hard numbers. These are squishier, softer limitations, which can still result in a benefit denial or a person paying more for their benefits. So these are kind of squishy limitations basically under your plan. So what do they include? Medical management standards, which limit or exclude benefits based on medical necessity or appropriateness, or whether treatment is experimental or investigational. Those are very, very common. I don't think I have a single client who doesn't have some kind of limitation like that. Basically, no health plan wants to pay for things which are not medically necessary. So that is an extremely common NQTL, and everybody wants that kind of NQTL. And when we get to the end of this, I hope you realize I'm not trying to say that that kind of NQTL is illegal. It's not strictly prohibited, but what you're going to have to do is you're going to have to build out documentation, as you'll see at the end here, explaining how your application of that medical necessity or experimental or investigational rule doesn't pick on, doesn't discriminate, isn't applied more stringently against mental health or substance use disorder benefits. So that's kind of the ultimate goal. That's sort of where we're steering the ship, if you will. Other NQTLs, formulary design for prescription drugs, network tier design, possible NQTLs there. Standards for provider admission to participate in a network. Reimbursement rates is kind of a big one. If the reimbursement rates are discriminatory against mental health providers. That can be a problem. UHC's unit actually got sued a couple of years ago over this exact issue, where it was the same kind of service which was being provided sometimes by a medical surgical provider and other times by a mental health professional. And UHC was paying a lesser amount for the mental health professional compared to the medical surgical professional, even though it was the exact same benefit. And so the federal government said you can't do that. You can't provide a lesser reimbursement rate for somebody who's doing the exact same service on the mental health side. So again, it can pop up, and there is case law out there on that. Plan methods for determining usual, customary, and reasonable charges. Again, how does your plan figure out what to pay the providers? What kind of databases are they using? Are those databases discriminatory or not? Again, there was another lawsuit involving a big provider that was out there where that provider was accused of sort of cherry picking its standards for how it came up with some of these NQTLs. Basically, what they had done was, allegedly, they had looked at, I think, 4 or 5 different resources for some of these NQTLs, and then they allegedly kind of went through each of those and when they're trying to figure out what's medically necessary or what the UCR amount should be, they tried to find the one resource which was a little bit better for the plan, the TPA, the insurer, compared to other resources, and then they grabbed that as the basis. And so basically, by cherry picking through 5 different resources, they came up with things which had some justification, but their method of determining those justifications really was improper, is basically what the court found. So again, these are things which kind of go on behind the scenes here, but which employers are now responsible for at least trying to figure out. Other NQTLs, refusals to pay for higher cost therapies unless lower cost therapies are not effective. Step therapy protocols, again, can be an NQTL, and those are pretty common too. Exclusions based on a failure to complete a course of treatment, geographic restrictions, facility restrictions, etc. So again, what these rules are going to force us to do here is identify the different NQTLs you have under your plan, like the ones I just went through. And that is not a comprehensive list. There's, in theory, an infinite number of NQTLs which are out there. You're only limited by your creativity or your TPA's creativity in terms of how, what kind of restrictions they want to come up with. So again, those are the core ones. Those are kind of the common ones, but your plan could vary. Your TPA could vary here too. And so what the rules say is that you are supposed to identify the processes, strategies, evidentiary standards, or other factors used in applying those NQTLs to mental health benefits within a classification, again, in-network, out-of-network, prescription drug, emergency, and those processes have to be comparable to and applied not more stringently than the processes used in applying the NQTL to medical surgical benefits in the same classification. So we call this the comparable processes rule. So that's kind of the goal here, is to have that kind of comparable process. In addition, you can't have separate NQTLs that are applicable only with respect to mental health or substance use disorder benefits. So again, that's, as you would think, kind of a core problem. If you only imposed medical necessity on mental health benefits, you never imposed it on medical surgical benefits, that would be problematic. And then each of these NQTLs within a classification must comply with the plan as written and in operation. And that in operation is a difficult one to comply with. We'll give you kind of an illustration of it coming up here. But the written SPD, you all are capable of reading through it, trying to identify NQTLs, trying to figure out, okay, do we have some issues here? Lawyers like me are very capable of reading your SPD, reading through it, identifying problems there. We do that for a lot of clients. But the in-operation piece of it is something that only your TPA, PBM, or other vendor can really look at. Only they kind of know how they sort of handle these back-end issues. And so that creates problems that forces basically employers to go to the TPA, go to the PBM, and try and clarify, hey, how are you actually administering this test? And we help out with that, you know, and other folks do too, consultants do, lawyers do. So again, that kind of analysis, I think, is going to be required. So basically, again, you kind of should be doing a two-part analysis here, trying to verify that the processes used in applying any NQTL to mental health or substance use disorder benefits are identified and then compared to the processes used for medical surgical benefits. That's helpful. That's kind of step number one. But I think you also have to dig deeper to make sure that the processes as applied are not more stringently applied against mental health benefits compared to medical surgical benefits. So in other words, just reviewing the plan documents is not enough, totally insufficient. And that is kind of mind-boggling to people. But we put together a little slide here on it, a little visual. When I talk to clients, I kind of describe it as an iceberg where the risk of the deficient SPD is small and fixed relatively easily. You can see that. You can look at the SPD, you can say, wow, okay, it looks like we're applying something more stringently here. But the bigger risk, I think, is everything under the water. It's the bottom half of the iceberg. And that's really the operations of the TPA and PBM or other health plan vendor, where you really need to figure out, okay, how are they figuring these things out? How are they doing this analysis? How do they come up with, you know, these different rules that they apply to our plan that we, the employer, don't even really know is going on? So again, think of it that way, that your bigger risk really is kind of below the surface level. And that is going to require you as an employer to talk to your vendors, poke holes against your vendors basically, and say, hey, you know, prove to me that you are compliant here. Prove to me that you have a good process in place. You kind of almost have to think of it as if I were a Department of Labor auditor or investigator, what questions would I ask? You know, how would I kind of push on them, probe on them to figure out, okay, where are the deficiencies that I can't see through the SPD, but which might be in existence kind of below the surface, if you will. So in terms of, you know, how we approach this, again, this was passed in December of 2020, pursuant to the CAA. And the CAA required that plans have to be able to provide a comparative analysis of the NQTLs in their plan, and you had to be able to provide it to the Department of Labor or plan participants or state regulators or CMS for non-ERISA plans. So they envisioned kind of a specific, detailed, written explanation of every NQTL that the plan has and how that NQTL is not applied more stringently against mental health benefits. When this first got enacted, nobody really knew what we should be doing here, to be honest and to be blunt. And then they did come out with some additional information in April of 2021, some FAQ documents, which are really helpful in terms of at least giving us a starting point for how to comply. The starting point has proved to be inadequate, and that's why we have some new regulations, but the starting point, the April 2021 FAQs, really should be the focus of where you are going right now. And so under those April 2021 FAQs, what do you have to do? First of all, describe each specific NQTL. So again, that kind of forces you to go through your SPD and look at it and say, okay, here's every single NQTL we have. Or alternatively, a lot of the TPAs and PBMs out there, a lot of them, but not every one of them, have put together what I call template MHPAEA starting point documents, where they have listed off, okay, here's every one of our standard NQTL. So at, you know, this particular TPA, ABC TPA, you know, we have 15 different NQTLs that we use. We use medical necessity, we use experimental, we use utilization management, we look at concurrent care, you know, things like that. We have 15 kind of standard NQTLs, and you as an employer probably use their standard NQTLs. It's theoretically possible that you could impose some additional ones, or you may impose less. So instead of 15, you could be at 16, you could be at 13. So it could vary a little bit, but definitely talk to your TPAs and PBMs about their template documents. Ask for their template documents. They should share them with you if they have them. And again, very helpful because that will help you with this number one here in terms of describing what NQTLs you have under your plan. And then second, you need to verify which of those apply in all these different classifications. So very typically, NQTLs apply for in-network inpatient, out-of-network, in all four categories, basically the first four. Emergency care. A lot of times NQTLs do not apply to emergency care, or at least some of these NQTLs will not apply. Why? There's a big difference in terms of applying an NQTL when someone is going in for like a knee surgery. You have time to think, hey, is that really medically necessary? Should we be applying step therapy? Should we be asking them to do rehab first? You have the luxury of time basically for the first four. For emergency care, it could be someone was in a car accident and they're unconscious and they're literally being taken care of in the ER room. There's no time to figure out a lot of these NQTLs in that situation. So again, some of them apply, others do not. Prescription drugs, similar kind of analysis. Most PBMs, in my experience, apply 3 to 5 NQTLs, while TPAs tend to apply 12 to 20 NQTLs. And so prescription drugs are usually just a lot easier to analyze because there's fewer NQTLs. The next step is to look at the criteria that was used in designing and applying those NQTLs, including the factors, the evidentiary standards, the sources, the strategies. Were any of those weighted more than others? So for example, many TPAs use a handful of different vendors who publish extensive documentation about what is medically necessary and in what situations. What's the treatment of care, what's the standard of care for a particular disease or medical condition. And so a lot of times what you'll see when you kind of, again, go below the surface of the water and you start asking these questions is you'll see that they tend to use these kind of resources, these third-party resources. And that's actually probably a good thing because, again, there's a handful of them out there. I think they're very professional, these third parties. They have documentation, they have research, they have doctors on staff or others that they can reach out to. So it's a good thing here in terms of, I think, of how most of the TPAs and PBMs out there kind of handle it. But again, you need to verify that you can show this is how they handle it, this is their strategies, etc. Quantitative factors. Do look at quantitative factors if there is some issue out there. For example, sometimes a plan will say, we're going to conduct medical necessity review, but only after 30 visits. And if it's across the board, 30 visits on the medical surgical side and on the mental health side, probably going to be okay. But if it's 30 visits for medical surgical, but after 10, we more stringently apply the medical necessity against mental health, that is going to be perhaps problematic. Again, you'd want to understand what are the sources for that? Why are we more stringent here? Why are we applying 30 visit rule here for medical surgical so someone can go to physical therapy 30 times? We don't really care. We never look at it. But if someone goes in for a mental health consultation after 10 times, suddenly we're looking at it more stringently. Again, it's not necessarily a problem, but you need to kind of verify why those numbers exist and how they came about. Right now, when we talk about the 2023 proposed regulations, you'll see that the DOL has gone back and forth on how much quantitative information a plan sponsor should obtain. So again, we'll give you kind of a hint of that at the end of this presentation, and we'll cover it in a lot more depth in January here in 2 months. Number 5, in terms of the things you should be thinking about right now, again, this is April 2021 FAQs. Identify any variations in how a standard is applied between mental health benefits and medical surgical benefits. Explain the process and the factors considered in making that determination. And again, know that I don't think you as a plan sponsor are likely to really have access to this information. This is one of those where you really have to go back to your vendors and say, hey, do you have any variation in these standards? And a lot of the big TPAs and PBMs now have been asked that question so many times that they're sick of it. So they built that into their template documents and said, we don't have any variation, or we don't give additional weighting in an improper manner. So again, kind of kick the tires there, figure out if your template documents say that or not. If they don't, that's a good follow-up question to the vendor there. Number 6, administrative decisions. If the application in the NQTL is based on specific decisions in the administration of the benefits, the plan must be able to identify the nature of the decisions, the decision makers, the timing of the decisions, the qualifications of the decision makers. And again, that is something that you as an employer will not have access to. That's literally within the TPA, who is making this decision? Are they trained? Are they nurses? Are they doctors? Appropriately trained staff, things like that. And again, that's invisible to you as the employer. So you're going to have to go and talk to the vendors and say, hey, we want to make sure that if we need to, you will provide us with this information. So that's a good takeaway point there. Experts, similar approach. If the plan or TPA or PBM relies on any experts, that you have to make available for each expert their qualifications and the extent to which you relied upon their recommendations with respect to these NQTLs. And again, these experts are not going to be housed within your employer organization. They're going to exist at the TPA PBM. Talk to the TPA PBM, make sure that you can gather this information if you need to, because again, it's out there under the DWEL guidance. Number 8, findings and conclusions, a reasoned discussion of comparability of these different processes, standards, factors, etc., used to design and apply the NQTLs, both as written and as applied. So again, they're looking for, what we think, kind of a 2-column chart or a multi-column chart. We say, okay, here's the NQTL, here's how we came up with it, here's why we designed it this way, here's how it applies to medical surgical benefits, here's how it applies to mental health benefits, and then a conclusion of, and therefore it's comparable, or a conclusion of, no, we're not comparable, we failed, we're applying it more stringently against mental health. For what it's worth, I've never seen a TPA or PBM take the position that they violate this rule. If they give you their template documents, I am 99.9% sure that the template documents are going to say that they're in compliance. Your question as a plan sponsor is that true? How do we push back on that? How do we, verify that? Trust but verify is sort of the approach there. Analyses details the date of the analysis, the name, title, and the position of the person performing the analysis, and others who participated in the analysis. So DWEL is looking for names, and that means that you need to kind of take it seriously and try to figure out, okay, how would we respond to this? Who's really in charge here? In terms of enforcement, there can be enforcement. There have been, again, a couple lawsuits that the DWEL has initiated. There's been a ton of lawsuits in general on mental health parity, usually often at the state level in terms of private plaintiffs bringing state law type of claims, usually against insurers more than self-funded plans. But if the DWEL finds that parity has been violated or that the comparative analysis is not provided or incomplete, in general, the plan has 45 days to take corrective action. After 45 days, if the DWEL finds that the plan is still in violation, plan under these NQTL rules must notify enrolled participants of the non-compliance within 7 days. DWEL is supposed to provide an annual report naming plans in violation, and actually they just did that recently. And one of the plans that they identified was in Milwaukee, Wisconsin. So it's kind of a name and shame approach, and they named the plan sponsor right in their report and said, we found them to be in violation. So that's definitely the goal here is to call out employers that they think are not being sufficient here. In addition, the DWEL can refer violators to the IRS, which could assess civil penalties of up to $100 per day. They could, in theory, bring a lawsuit to force a change here too. And in terms of other kind of political considerations, this remains a top priority under the current Democratic administration, but keep in mind, again, this law was signed by the Republican Donald Trump. So we have bipartisan political support basically for mental health parity. Both Republicans and Democratic leaders really want to see parity out there. It's an important political goal. So a lot of pressure here is what I'm basically saying. And in terms of implementing this, what does all this mean in the real world? What would a sufficient comparative analysis look like? Again, nobody really knows for sure. Most of the big TPAs and PBMs have this kind of template document with multiple columns and charts, and that I think is a pretty good approach as far as we can tell. It's a little bit scary though, because the DOL has issued some guidance saying that basically the industry is not doing very well. So in a DOL report to Congress in January 2022, DOL said that it had issued 156 letters to plans and insurers requesting comparative analyses for 216 different NQTLs, and it found that none of them reviewed to date have contained sufficient information upon initial receipt. So in other words, basically the entire industry failed. And they said, you know what, you're at 100% failure level here. So the industry kind of pushed back and said, well, wait a minute, it can't be that literally everybody is failing. There's a 0% success rate. This really can't be our problem. If every student in the classroom fails, basically the problem should be with the teacher. The teacher's not doing a good enough job. So can you get us additional guidance here? And under the statute, DOL, IRS were supposed to issue more guidance. They're a little bit late in getting it out, but in July 2023, late July 2023, early August 2023, we did receive that additional guidance. And it's one of those things where I guess, beware of what you ask for, because the additional guidance is in the form of these proposed regulations is very stringent. Some have said it's unworkable. Some have said it's really, really strange. And we're going to cover this again in January 2024, those proposed regulations. And they are complicated, and that's why we're going to have a whole another webinar just on that piece of it. So what else did they issue here? Technical release and then a comparative analysis report to Congress. The comparative analysis report indicated that most of the industry is still failing, that they've continued to ask for these written analyses, and the vast majority of them are failing. But apparently it's not a 100% failure rate. Maybe it's only a 90% failure rate or 95% failure rate. So again, we as an industry have improved a little bit, but we're still in hot water, I guess, from the DOL's perspective. In terms of these proposed regulations, they're only proposed. The comments were due in mid-October 2023. Regulators have said that they hope to have final regulations be effective for plan year starting January 1, 2025. And in order for them to have sufficient lead time for us to comply as of January 1, 2025, that suggests that final regulations might be released first quarter 2024, maybe. We're not quite sure. But our intention is that we're going to do, again, kind of a deeper dive in January 2024 on the proposed regulations. And then I would guess if they do come out with final regulations, we might have to do a follow-up webinar to kind of explain what the differences are between the proposed and the final. Other practical considerations, other thoughts here. Basically, no plan sponsor can do the analysis alone. Your TPAs, PBMs are the experts, and you need to work with them to figure out how they're handling things in operation, how are they coming up with these NQTLs, how are they applying them. Also, legal review may be necessary. Some folks are okay with that, others are not, but there certainly is a lot of legal ambiguity out there. One other thing under the regulations, proposed regulations, is that a plan fiduciary for an ERISA covered plan is going to have to certify in writing by their name that the plan is compliant with these rules. And so that's very unusual, but the DOL is really looking to have one identifiable person they can blame, basically, if something is wrong. And if I'm the fiduciary who has to sign that, I'm going to be nervous because there's so many potential, pitfalls and potholes here. So I think that that'll put a lot of pressure on those fiduciaries here to really have this be very well researched and thought through. The DWEL does have a self-compliance tool. If you Google it, you can find it very quickly. But note that many of the questions that the DWEL asks are not in there. So the tool is helpful, but I would say not sufficient. We did have a question on that before the webinar. What steps should you be thinking about right now? I think most plan sponsors are trying to comply right now with the 2021 FAQ guidance. Most plan sponsors are not trying to comply with the 2023 proposed regulations. So basically that's what I'm seeing is everybody's like, okay, let's at least make sure we're good under the 2021 rules. We'll wait and see what happens in 2024 with these regulations. And then hopefully in 2024, if we need to do some cleanup work, we'll handle it so that we're in compliance by January 1, 2025. Or later, the industry did push back and say, hey, maybe this should really be January 1, 2026, is what some of the big vendors said there too. So again, we think that's probably a good approach is, don't wait, do the 2021 analysis basically now. A little bullet point here in terms of a pitch, if you will, for our services. What we have done for some clients here is when they have a common TPA or PBM, basically we can split the cost of reviewing those template documents, and that can bring the cost down significantly. If the cost is $20,000 and we have 4 clients who use that same TPA, we just divide the cost 4 ways. So that can actually be really helpful in terms of bringing down the cost, again, when there are common folks. If you want more information on it, feel free to email me, call me. The Alliance has my contact information, or you can just look it up online too. Other practical considerations, again, I think you should be looking to, finalize your current process if you have started it. If you haven't started it, you should start it now. Maybe even consider refreshing it. One of the questions we sometimes get is, do we have to do this kind of analysis every single year? And what I've been telling clients is probably not. You probably don't have to do this annually, but if you have a significant plan design change, you mix things up, or if you change TPAs or PBMs or other vendors, you definitely have to look at it fresh, because going from TPA number 1 to TPA number 2, totally different, analyses, totally different behind the scenes. Again, think of it like an iceberg. What's below the water for TPA number 1 is not going to be the same as what's below the water for TPA number 2. So again, do think of it in that way. I think that's a good way of approaching it. So we'll see. We'll see what happens with, again, these rules here. And there's my contact information again if you wanted to follow up on that piece. And with that, I think we are going to check and see if there are questions here.
Thanks so much. There are some questions. You had already addressed how often NQL testing should be done. Thank you for just doing that. There's also a question on, I guess, how they can best clarify what's needed, and it sounds like maybe you're recommending some legal advice there.
Yeah, I think so. I mean, it's, I think talking to either a lawyer or, consultant with experience in this, I think is probably a good idea, because there are so many moving parts. And, the more that I've done this, the more things I've seen, where I've kind of spotted issues from one TPA, now I've learned kind of from them, and so I apply that same kind of question to other TPAs and PBMs. So this is probably the most difficult area of benefits compliance that's out there. If a client says to me, hey, can you draft a COBRA notice? It's like, sure, that's easy. But, if a client says, draft reports on NQTLs, that's way harder. So this is a very difficult area. And again, the DWEL is actively enforcing it still. So it should be a high priority, I think, for employers.
And what do you see as the responsibilities for employers? I know you kind of went through that, but that was one of the questions that we got before the webinar. And I don't know if you have a simple synopsis or if it's just engaging with you and others to try and figure it out.
Yeah, from a fiduciary duty perspective, every ERISA plan fiduciary, and most of the folks on here I think are subject to ERISA. Obviously, we could have some non-ERISA folks on the line here today, but most of you are subject to ERISA. And one of your core ERISA fiduciary duties is to make sure that you're following the law and that your health plan is following the law. And again, if you think back to that iceberg analogy, definitely take a look at your SPD, look for those NQTLs. That's the above the water piece of the iceberg. Definitely should be doing that right now. And then, focus on the below the water piece of it. Talk to your vendors. You have to talk to your vendors. There's no way you can see the bottom half of that iceberg without asking them questions, without probing. And again, I've described it to clients as you kind of got to put on your imaginary Department of Labor investigator hat. If you were an angry DOL agent, what questions would you be asking? How would you challenge them? Things like that. Think of it in that term, and I think that gives you the mindset that you should be approaching it with.
And hopefully we get a non-angry one. That would be
right, exactly. I'm sure they're lovely people, but in general. But that if you prepare for the worst, you'll be ready.
Yeah. We have a question about how mental health benefits address nutrition, and actually just received one about some legislation around obesity becoming a mental health issue, and if that falls under this act. Can you speak to either of those?
Yeah, so in terms of nutrition, so what's one weird thing about mental health parity is it doesn't actually mandate particular levels of benefits. So you could, in theory, just not cover any mental health benefits. And I do have a handful of clients who take that approach. They just don't cover anything from a mental health perspective. That is not the typical approach. It makes it way easier to comply with mental health parity because you don't provide anything. So that's the easiest kind of course. But so in terms of like nutrition, again, mental health parity doesn't mandate that you cover nutritional benefits at all, but it is a sensitive subject where if you do cover it, then you have to comply with mental health parity. And nutrition does come up, sometimes when there are situations, especially involving mental health issues, and anorexia, bulimia, things like that, where people have eating disorders. Nutrition becomes an important characteristic of their treatment there. So certainly there will be limitations that your TPA or PBM is imposing there on the nutritional side. You should look at it and say, okay, how are they figuring that out? And then in terms of obesity, I haven't seen that question before. My gut reaction is that obesity is probably on the medical surgical side as opposed to the mental health side. But I'm not 100% sure of that. I could see someone with a mental health issue which causes them to overeat. So I think you'd probably have to look at it a little bit in more detail to figure out what's the nature of the obesity. Because again, if it's driven by mental health issues, I could see it falling into that mental health category as opposed to medical surgical category.
Which is, I think, why during this presentation you suggested if it was the same across the board, it would probably be easier if you kind of had the same co-insurance and deductibles across the board.
For sure.
One other, I'm going to try and cover just a couple of questions. I know we're running out of time. Will the No Pain Act impact employers and their benefit plan design?
Yeah, so that's a good question. So in general, that one really should not impact employers. It seems to be more at the governmental level in terms of the coverage of that particular act. It does raise a broader question, though, of how do employers kind of monitor these rules? Because in Congress at the federal level, probably every day there's one or two new bills which are submitted for consideration that impact employee benefits in general. Certainly not always on the mental health parity side, but it can be a little bit difficult to try to monitor all these bills. You could spend half your working day trying to figure out what's new out there. So in general, our approach has been wait until it gets enacted by a particular committee, approved by a committee, approved by kind of a group of people within Congress, rather than trying to monitor every single bill that's out there, because you kind of lose your mind after a while because there is so much that's out there. But that specific one we think really won't impact anything here.
And then the last question I'll ask, didn't Obamacare mandate mental health parity? That was a question we received.
Yeah, so it did not. So the Affordable Care Act, sometimes called Obamacare, really didn't make any significant changes here to this area. So it is a little bit hard to keep track of it, because in the past 15 years we've had so many different rules and regulations and laws and things like that. So ACA did not really make any significant changes here, did not mandate the parity, but again, other laws enacted shortly before ACA and after ACA basically are what we're dealing with.
Great. We're out of time, but I just want to thank you so much today. This was some great information. So thank you for being here, John, and we look forward to seeing you in January again.
Sounds good. Thanks.
Great. So I'm just going to wrap up today's event. If you need additional resources, if you want to connect with John and you need some help, please feel free to reach out to me. We've got a lot of experience and we're happy to help you, whether you're a member of the Alliance or you just like to learn more. We do have those handouts available to you that I mentioned earlier today. They're available in the GoToWebinar platform, and they will be available after this event on our website. If you need them, feel free to email events@the-alliance. And don't forget about that employee handout that we created as well. While John mentioned that you could just not cover mental health benefits, we hope that you will. We hope that you make that a priority and you help encourage your employees to make it a priority for themselves as well. There will be a post-event survey, and if you need to request CE credits, please feel free again to reach out to the Events@the-Alliance. We really appreciate your feedback. That's what helps make these events what they are, and your feedback helped us figure out what we needed to have for this event, which is 2 events to go a little bit more in depth. Don't forget, we've got some great upcoming events. We are doing a webcast of the Fall Symposium and Annual Meeting. It's worth pointing out that we had an exclusive keynote speaker that will only be available on the webcast. It won't be available later. So if you missed it or you want to see it again to figure out what's coming for 2024, register. And then we'll have part 2 for today's webinar in January. Thank you again for joining us today. And remember, when you think of the Alliance, please think self-funding smart. We'll see you next time.